Good afternoon, everyone. My name is Kathleen Cook, and I will be moderating today's session. It is on retinoblastoma, germ cell tumors, and hepatoblastoma, and will be presented today by Dr. Carlos Rodriguez Galindo from St. Jude Children's Research Hospital. A few announcements before we start. Don't forget to network with the colleagues in the chat box at the bottom and utilize the Q&A feature that will be able to ask questions for the speaker. If you see other questions that you would like to see answered, you can click the vote for the question. It's a little hand symbol to raise the question to up on the priority list. Following the lecture, there will be a dedicated live Q&A time at the end of the presentation. If you experience any issues viewing the session, please try refreshing your screen or visit the support tab at the top of the screen. Now I will turn it over to Dr. Rodriguez Galindo.
Okay, hello, good day, good afternoon. I'm Carlos Rodriguez Galindo, and over the next hour, we'll try to go over four major topics: retinoblastoma, germ cell tumors, hepatoblastoma, and other rare tumors. I have no conflicts of interest, and we will structure this talk with the topical structure suggested by the EVP, trying to address basic science and pathophysiology, epi and risk assessment, diagnosis, and then treatment. So we have a busy agenda with four major categories of diseases. So in some sections, I may just give you the slides as a reference, but I may just not go in detail in interest of time. But hopefully the material will be helpful to you as you go through your studying. So let's start with retinoblastoma. So retinoblastoma is a rare cancer, but accounts for about 3% of all pediatric cancers. It's 11% of all cancers in the first year of life. And the majority of patients, 2/3 of them, are diagnosed before 2 years of age, 95% in the first 5 years of age. Laterality is age dependent. So in the first year of life, 40 to 50% of patients have bilateral disease. After 2 years of life, the majority of patients, more than 90%, have unilateral disease. So by now, you already know that there are two clinical forms. One is the unilateral unifocal that we also call non-heritable, which accounts for about 75% of the patients, in which the mutation of RB1 occurs in both alleles in a somatic cell, and the median time to diagnosis is about 30 months of age. And then we have the bilateral multifocal, or also called heritable retinoblastoma, which accounts for about 25% of the cases. And these are patients that are born with a germline mutation of RB1. The majority of cases, however, this mutation is de novo that occurs during early embryogenesis, and only 25% have been inherited from a carrier parent. The median time to diagnosis is a bit earlier, about 14 to 16 months. So then the biology, as you know, is biallelic inactivation of RB1, which is almost universal. It's the first hit is germline in the heritable form, and it's somatic in the sporadic non-heritable form. So the germline mutations occur often in the paternal allele, and that's associated with some paternal environmental exposures. And in a small proportion, less than 5%, this is not a mutation, but a deletion. And so this is associated with intellectual disability and other dysmorphic features that we call the 13q- syndrome. But biallelic inactivation of RB1 is not enough. There are additional events that are required for transformation. Some of them occur in the p53 pathway with amplification of MDM2 or MDM4, but there are other epigenetic alterations like BCOR mutations or SIG upregulation. And then remember that about 1.5% of the cases do not have any inactivation of RB1. These are cases with an N-MYC amplification like neuroblastoma, and this is associated with a worse outcome. So some facts to remember for heritable retinoblastoma. So first, as we said, the germline mutation is associated with greater than 90% penetrance. There are very few silent carriers. So all patients that are born with bilateral retinoblastoma have an RB1 mutation. As we said, 75% de novo, 25% inherited. But remember the 15% rule. 15% of patients with unilateral retinoblastoma do carry a mutation, and 15% of patients with a germline mutation develop unilateral retinoblastoma. And then remember that there are mosaics for RB1, which are cases in which the mutation occurs in late embryogenesis with variable tissue expression, and is estimated about 10% of patients with de novo bilateral retinoblastoma are mosaics. So thinking about genetics then and genetic counseling. So we indicate genetic counseling in all patients, regardless of laterality and their families. But need to remember that mutations are distributed throughout the 27 exons of the RB1 gene. There are no single mutational hotspots, as it happens with other tumors, and it requires a comprehensive genetic testing to really detect those mutations. So whenever you want to screen relatives, you need to know the specific mutation of the proband, as you can imagine. And then all offsprings and newborn siblings of survivors of retinoblastoma must be screened at birth and every 4 weeks until the genetic testing is complete. And then a baby with a positive testing will require dilated eye exams every 4 weeks due to the high penetrance of the mutation. So how does retinoblastoma present? So when retinoblastoma presents intraocularly, the most common presentation is what you see in the picture is leukocoria, followed by strabismus or nystagmus. When the tumor grows and it fills the entire eye globe, tumors may present with ophthalmos, some patients with glaucoma, and some cases periorbital cellulitis, which is due to intraocular tumor necrosis. And then when the tumors exceed this growth and become extraocular, you tend to then see proptosis, orbital masses with lymph nodes, or metastatic disease. How do we examine to evaluate retinoblastoma? First, we need to do a good examination under anesthesia. Both eyes need to be examined. The ophthalmologist has to have a direct visualization of the tumor, evaluation of the corneal diameters and the intraocular pressure to evaluate for glaucoma. An ocular ultrasound is the first test that is usually done, followed by MRI of orbits and brain that are important for optic nerve extension prior to enucleation and for evaluation of CNS disease to rule out trilateral retinoblastoma. Bone scan, bone marrow aspirate and biopsy, and CSF cytology are only performed in cases of advanced disease with high-risk histology, as we will discuss later. And then, as we said, all patients should have genetic counseling. The differential diagnosis of retinoblastoma is quite extensive and needs to be completed. And the evaluation has to be done by an experienced ophthalmologist because clinical decisions are done without a biopsy, obviously. So congenital cataracts, Coats disease, persistent fetal vasculature, or PFV, retinitis, toxocara or toxoplasma retinitis, meduloepithelioma, astrocytic hamartoma, and choroidal osteoma have to be included in this differential diagnosis. How do we stage retinoblastoma? There are two concepts that we need to remember. One is how we stage the eye, and we call it eye classification. And the stages are groups, and then how we stage the patient, and that's the retinoblastoma staging. So how do we stage the eyes? That's what we call classification, and we use groups. And so that's developed in the 2000s based on ocular salvage using modern conservative approaches, and it's based on the size and the tumor burden within the eye, the location in relationship to the foveola and the optic disc, the presence or absence of subretinal fluid and seeding, and the presence or absence of vitreous seeding. So we have 5 groups, A, B, C, D, and E. You have in the table on the left the description that you don't need to memorize, but remember A, B, C, and D are progression of a tumor as it grows inside of the eye. So how do we stage the patient? So there are 2 concepts that we need to remember. One is this intraocular or extraocular. And then within intraocular is extraretinal or intraretinal. And we'll review that a little bit later. But with those 3 concepts, then we stage the patient into 5 stages. Stage 0 is reserved for patients that are treated conservatively. So these are patients that do not have an enucleation, and so we refer to the group classification. Then stage 1, 2, 3, 4 are based on the progression of the tumor, completely resected, eye resected, but with microscopic residual, either in the sclera or in the optic nerve. Stage 3 is regional extension, that's orbital disease or nodal disease, and stage 4 is metastatic disease, either hematogenous metastasis or CNS extension. So how do we treat retinoblastoma? Two key concepts that we need to remember. First, you need to have a multidisciplinary team with an oncologist, an ophthalmologist, a radiation oncologist, the right infrastructure and supportive care, and several priorities. Start with curing the patient, obviously, then eye salvage, and then vision preservation. You do not change the order of those three. And we add a fourth priority, which is to avoid or delay radiation therapy. So treatment of retinoblastoma then needs to be individualized by stage and group, by laterality, and there are major concepts that you need to remember. One, ocular preservation versus enucleation. Second, risk adaptation, intraocular, orbital, or extraorbital. Third, is this unilateral or bilateral? And fourth, can we delay or avoid radiation therapy for all the late effects that it might have? So let's just start with these two main categories, treatment of intraocular retinoblastoma and extraocular retinoblastoma. For intraocular, we'll review this concept of ocular salvage versus enucleation, and we'll put it together for unilateral and bilateral disease. So let's just start with ocular salvage versus enucleation. So here you have the continuum of the disease, A, B, C, D, and E. So the factors influencing the initial treatment decision, enucleate or salvage, will be the group, how much disease the patient has, the potential for vision, and the laterality. So the decisions need to be made in this continuum of tumor progression. For example, ocular salvage chances are very high in group A and very low in group E, and decisions have to be individualized in between. Favorable visual outcomes decrease with increasing intraocular tumor burden. The intensity of the treatments required for ocular salvage also increase across the continuum. In general, ocular salvage options are not offered for the end of the spectrum, groups E and many groups D eyes, and upfront enucleation is always recommended for those. And then treatment for patients with bilateral retinoblastoma is a little bit more conservative, and decisions regarding enucleations are usually delayed. So let's talk about ocular salvage. So if we have decided that we can and we want to save that eye, these are three components. One, chemo reduction, so chemotherapy to reduce the tumor burden, and that can be given systemically or intraarterial chemotherapy or intravitreal chemotherapy. And intravitreal is usually used for treatment of vitreous seeds in conjunction with the others. I am not advocating for systemic versus intraarterial chemotherapy. These are decisions that need to be made at an institutional level based on resources, capacity, and expertise. The second component is focal treatments. So the focal treatments are used to consolidate the responses after chemotherapy. Small lesions, less than 4 disc diameters, treated with cryotherapy or thermotherapy. Larger lesions need most likely brachytherapy, which is a radiation plug that is applied outside of the sclera. And then, as we said, radiation therapy is very effective and can be used when other measures have failed, but we try to reserve it to its side effects, long-term effects. So we have talked about ocular salvage. Now, enucleation, we have decided that the best treatment for the patient is enucleation. So enucleation is upfront recommended for almost all group EIs. It's a good alternative to ocular salvage depending on laterality. It's used after failure, and it requires an expert surgeon because we need to remove a 1 centimeter section of the upnerc with the eye for proper staging. And usually at the same time, the ophthalmologist places the orbital implant. Following enucleation, we do a good histopathological exam. So what do we look for in a histopathological exam? We look for high-risk histology, that is what we called earlier extraretinal disease, which is present in about 20 to 25% of the cases. What defines high-risk histology is massive choroidal replacement, ciliary body infiltration, iris infiltration, scleral invasion, invasion of the anterior chamber, or involvement of the optic nerve past the lamina cribrosa, or if it's before the lamina cribrosa, when it has concomitant choroidal involvement. So a presence of high-risk histology is indication of high-risk disease, so the risk of dissemination. So additional staging studies and risk-adapted therapy are required, which is the next step. So we have decided that there are no high-risk features in the pathology. That's intraretinal retinoblastoma, completely enucleated, stage 1, observation We examine the orbital socket periodical, examine the contralateral eye. Outcome is greater than 95% without any adjuvant therapy. High risk histology requires then additional staging workup. We now then bone scan, bone marrow aspirates and biopsy CSF. If they are negative, then we treat with adjuvant chemotherapy and the outcome is still excellent. If they are positive, then the patient needs to be treated as metastatic, and we'll review that in a second. Okay, how do we put all this together for unilateral retinoblastoma? So unilateral retinoblastoma usually presents with advanced intraocular disease. When you see this picture, you tend to assume that the tumor affects 2/3 of the eye globe. The options in this case, upfront enucleation and risk-adapted adjuvant therapy for the majority of patients. And so risk pathology or non-risk pathology, and you decide whether the patient needs chemotherapy or observation after that. If the patient has early intraocular disease, A, B, C, and some Ds, treatment could include chemo reduction with intraarterial systemic chemotherapy and focal treatments, and excellent ocular salvage rates are possible. As we said, ocular salvage is not indicated for advanced intraocular disease, and we always recommend upfront enucleation. I have here a picture that you can, or slide that you can use for your practice just to help you guide through the process and make decisions based on the group. We'll not go over that, but you can review that at your own time. So how do we put this all together for bilateral retinoblastoma? So for bilateral retinoblastoma, we need to think differently because it's multifocal, not just bilateral. So a lot of tumors may develop in each eye. It's also a dynamic process, not just what you see today is what you will be seeing over the next 2 or 3 years until the kid is about 4 or 5 years of age. Then the treatment decisions must include for each one of the eyes the tumor burden, the potential for vision, the status of the contralateral eye, and the risk factors for ocular salvage will be the size, the seating, and then the retinal detachment and the seeds, as you can imagine. So the treatment is a little bit more conservative for bilateral retinoblastoma than for unilateral. We tend to be more conservative in the sense of using upfront chemotherapy, upfront intraarterial systemic chemotherapy, very aggressive focal treatments, because you never know what's going to happen in this dynamic process. An eye that you thought was going to be the worst may actually respond very well, and an eye that you thought that was doing well 2 years from now may get worse. So that's why we tend to be a little bit more conservative. Then think that radiation therapy is very effective for poor responders, but we avoid it because of the side effects of radiation on growth and because of the second malignancies. And then also the timing of enucleation and irradiation depends, as we said, on the status of the contralateral eye. In general, in good hands of a multidisciplinary team, ocular salvage rates can approach 90% and survival is greater than 90%. And again, here you can use at your own time, just go through the different categories of retinoblastoma, and that can help you kind of guide decisions as the patients go through treatment. So we have talked about intraocular disease. So how about extraocular disease? Two main categories, orbital and metastatic. Orbital is usually considered to be any case of transscleral involvement or positive cut end of the optic nerve or massive orbital disease. It's associated usually with preauricular or cervical nodes, and you need to look for those. And the treatment is with cisplatin-based therapy, enucleation, and radiation therapy, and is curative in greater than 70 or 80% of the cases. Extraorbital disease is very rare in the US. It's more common in countries with limited resources where patients take longer to get a diagnosis. Metastatic sites are the bone marrow, the liver, and the brain. The extra CNS disease is curable with greater than 70 to 80% survival with cisplatin-based therapy and consolidation with high-dose chemotherapy and autologous stem cell transplant. CNS disease, leptomeningeal disease, or masses have a dismal prognosis. Less than 20% of the patients survive even with transplant. So what are the long-term effects of retinoblastoma therapy? Some of them are related to chemotherapy, hearing loss with cisplatin and carboplatin, therapy-related AML, but remember that survivors of heritable retinoblastoma do not have an added risk beyond chemotherapy exposure, and cardiotoxicity for those that receive doxorubicin. Radiation therapy is associated with facial deformity and second malignant neoplasms, and then think about ocular late effects, decreased vision due to the treatment or the tumor itself, retinal vasculopathy due to the tumor, to the radiation therapy or the intraarterial chemotherapy, and dry eye due to radiation therapy. And then, as you know, second malignant neoplasms are the most significant side effects. And so second malignant neoplasms have a high cumulative incidence, up to 36% at 50 years. And obviously these are in patients with bilateral or heritable retinoblastoma. Most are radiation-induced. Radiation exposure almost doubles the risk of second malignancy. 60 to 70% of second malignancies are in the head and neck area. There is a dose effect, higher dose, higher risk of second malignancy, and also an age effect. The younger the patient, particularly before the 1 year of age, the higher the risk of a second malignancy after radiation therapy. The most common malignancy in survivors of bilateral retinoblastoma is osteosarcoma. That is the most common inside and outside of the irradiated field. The second are soft tissue sarcomas, about 10 to 15% of the second malignancies. Again, more common inside than outside of the radiation field. Leiomyosarcoma, fibrosarcoma, malignant fibrous histiocytoma, and others, including embryonal rhabdomyosarcoma. The third are skin cancers, particularly melanoma. And the fourth are lung cancers and other common cancers of adulthood as survivors reach the fourth, fifth, and sixth decades of life. Then one of the second malignancies you need to remember because it's common during pediatrics, the pediatric ages. So that's the trilateral retinoblastoma, which is defined by a bilateral retinoblastoma together with an asynchronous midline intracranial tumor, usually in the pineal gland. Pineoblastoma occurs in about 3 to 10% of bilateral retinoblastomas, with a median interval between bilateral and trilateral retinoblastoma of about 35 months, so by 4, 5, or 6 years of age. It has a very poor prognosis, and that's because in lower vertebrates it occurs, because in lower vertebrates the pineal gland is a photoreceptive organ. So we usually recommend MRI every 6 months until about 5 or 6 years of age for children with bilateral retinoblastoma, although there are no good studies that show any impact on outcome. Okay, let's go to the second category, liver tumors, mostly hepatoblastoma. So pediatric liver tumors are very rare as well, about 1% of all malignancies in children, about 100 to 150 cases per year in the United States, and usually affects infants and young children. The median age of a liver tumor is about 19 months. So I have two categories, hepatoblastoma, which is the third most common intra-abdominal neoplasm, highest incidence during infancy, and 90% of the cases occur before 5 years of age. And then hepatocellular carcinoma, which is a malignancy of adolescents, accounts for more than 95% of liver malignancies after 15 years of age, and then is more frequent in Eastern Asia, in areas where there is a high incidence and prevalence of hepatitis B infections. So the differential diagnosis of pediatric liver tumors, I would say, has two main age groups. And you have this table that you can go in more detail. In the first 3 years, in early childhood and infancy, hepatoblastoma has to be considered in any primary liver tumor, and the differential diagnosis is mostly vascular tumors. In children older than 3 years of age, think about hepatocellular carcinoma with a differential diagnosis mostly of sarcomas. So hepatoblastoma biology is characterized almost universally by activation of the Wnt pathway. So you will see activating mutations in beta-catenin in more than 90% of the cases, and upregulation of some of the Wnt signaling pathway genes. About 5% of the cases have an NRF2 mutation, which is associated with a worse prognosis. Then other alterations that probably are not needed to be remembered are also common. So the risk factors for hepatoblastoma are very well defined. Several congenital syndromes like familial polyposis, Gardner syndrome, and overgrowth syndromes, and then some environmental factors, particularly prematurity and low birth weight. So we'll review some of those. First, Beckwith-Wiedemann syndrome is a very complex multigenic disorder, very rare, characterized by overgrowth, abdominal wall defects, macroglossia, GU malformations, organomegaly, as you very well know. But the malignancy risk is about 8 to 10% during the first decade of life. The most common is Wilms tumor, followed by hepatoblastoma, adrenocortical tumors. Hemihypertrophy is even rarer. It can be isolated or associated with Beckwith-Wiedemann syndrome or other syndromes. And the malignancy risk is a little bit lower when alone, when it's isolated, it's about 5%. And again, the same tumors, Wilms, hepatoblastoma, adrenocortical tumors. Prematurity and low birth weight is very well known as a risk factor, and we know there is a disproportionate number of cases with a birth weight below 2,500 grams, and the relative risk increases with lower weight. The fourth one is the familial adenomatous polyposis and Gardner syndromes. So these are cases with a germline APC mutation. In familial adenomatous polyposis, you will encounter other tumors, particularly desmoids. And in these cases, at birth, you can diagnose them or predict based on the presence of a congenital hypertrophy of the retinal pigment epithelium. That's a good way to screen for some of these patients. Gardner syndrome is associated with osteomas, and the estimation is about 5 to 10% of cases of hepatoblastoma have one of those syndromes. So that is important for family history. And we currently recommend APC testing for all cases of sporadic hepatoblastoma. So the lifetime risk of hepatoblastoma in children of FAP families is about 1 in 250 compared to 1 in 100,000 in the general population. And the relative risk in these families is about 800. So how do hepatoblastoma presents with usually is asymptomatic. Some cases may have weight loss, anorexia, emesis, or abdominal pain. Almost universally, will you see elevation of AFP? About 20% of the cases have distant metastases, and it's common to find thrombocytosis. Just remember thrombocytosis in a case of a liver tumor, and that's because hepatoblastoma cells secrete IL-1B that actually eventually may lead to thrombopoietin secretion. Hypertension is also rare, but it's because some tumors may secrete renin, and precocious puberty is also rare, and that's because of the secretion of beta-HCG. So hepatoblastoma, for evaluation of hepatoblastoma, start always with an ultrasound with Doppler. It allows you to evaluate cystic versus solid masses, the patency and involvement of the vascular system that are important for staging and for the surgeons. Then follow with a CT scan of chest, abdomen, and pelvis, or an MRI that defines the extent of the tumor, the vascular supply, and the operability. Laboratory workup always have to include an AFP that is elevated in more than 80 or 90% of the cases, and is very helpful for monitoring. The biologic half-life is, however, very long, and so that helps you think about how to measure a response to therapy. And then for pathology, if you do a biopsy, you need to do multiple passes because there are different histologic subtypes intermingled in the same biopsy. And that's basically how it is. So about 85 to 90%, the pathology is epithelial, which has components of fetal and embryonal hepatoblastoma that you see on the picture on your right. About 7 to 10% have pure fetal histology, and these have an excellent outcome, and stage 1 can be cured with surgery only. Then about 5% have what we call a small cell undifferentiated histology that has a worse prognosis, usually associated with low AFP and usually associated with 22q11 aberrations like any rhabdoid tumor. And so we tend to equal those to malignant rhabdoid tumor, and by staining, you will see loss of INA1 expression. So think a little bit more about alpha-fetoprotein. So it's elevated in the majority of cases of hepatoblastoma and about 60 to 70% of cases of hepatocellular carcinoma. The differential diagnosis is with germ cell tumors. And remember, pancreatoblastoma may also present with elevated AFP. It's lower normal in patients with the fibrolamellar variant of hepatocellular carcinoma that we will see in a second. And patients with low AFP tend to have a worse prognosis because it correlates with the small cell undifferentiated histology. It may also be elevated in other syndromes such as hemangioendotheliomas or mesenchymal hamartomas. The staging of hepatoblastoma follows two schools. One is the surgical criteria, assuming that surgical resection is the mainstay of therapy, then we stage based on surgery, and that's what it's used currently in most of the centers in North America. Complete resection, microscopic margins, gross residual, or metastatic disease. And then there is the radiographic criteria that we are also using more and more, that it's popularized by SIOPEL in Europe, which is which uses preoperative chemotherapy for all patients, and is called PRETEX, pre-treatment extent of disease. And that's PRETEX staging. PRETEX 1, which means that there are 3 contiguous sectors free, PRETEX 2, 2, PRETEX 3, 1 single sector in the liver that is free of tumor, and PRETEX 4, all 4 sectors are involved. You can spend more time going over these figures. So what are the principles of therapy of hepatoblastoma? First is risk-adapted therapy based on stage and pathology. Surgical resection is key, but only 20 to 30% of patients have resectable disease at presentation. And we have said already that surgery is curative for greater than 90% of pure fetal hepatoblastoma. Then remember that hepatoblastoma is a very chemosensitive disease. Usually we use cisplatin-based therapy. Chemotherapy increases the proportion of patients that can achieve a complete resection, and it's used in neoadjuvant and adjuvant settings based on risk assignment, as we will see in the next few slides. Then remember, radiation therapy is not indicated in the upfront treatment of hepatoblastoma. So what type of chemotherapy we use for hepatoblastoma? It's in general cisplatin-based regimens with some variations. In the COG in North America, the standard for many years has been cisplatin, 5-FU, and vincristine with or without doxorubicin. In Europe, SIOPEL has used cisplatin alone or with doxorubicin, and that's what we call Plato. There are other agents that can be used as well, mostly in patients with relapse or metastatic disease. And then the use of chemotherapy is based on resection. And so we can use it neoadjuvant versus adjuvant chemotherapy. In COG, we tend to start with surgery whenever feasible, followed by chemotherapy. In Europe, they always use preoperative chemotherapy. And then there is a trial right now that you probably have seen in all your centers, that is the AHEP 1531, or also called the FIT trial, which is a consensus COG-SIOPEL approach that uses both models and both regimens. So in general, assuming or considering that the treatment is evolving through these joint trials, but in general, these are the principles of care for hepatoblastoma. You can consider patients that have low risk disease, that's stage 1 and stage 2 non-small cell undifferentiated. So patients with microscopic residual disease that do not have small cell components, usually upfront surgery and maybe 2 or 4 cycles of chemotherapy are curative. And remember that pure fetal histology can be cured with surgery only. Then you have the big group of patients with intermediate risk that in principle, we consider the early stage small cell undifferentiated, or the others, stage 3 that are not metastatic. And in general, we use upfront surgery or preoperative chemotherapy followed by surgery and about 4 to 6 cycles of chemotherapy. And the survival is excellent, or the outcome 70 to 9%. And then high-risk patients that are patients with a stage 4 disease, and the majority of patients or all patients with a low alpha-fetoprotein that we assume it might just correlate with worse outcome. So usually we include a pre-transplant evaluation for many of these patients when they are PRETEX 4 particularly, preoperative chemotherapy, surgery, and postoperative chemotherapy, and the survival is about 40 to 60%. We mentioned liver transplant. When do we need liver transplant? So we need it for about 10% of the patients. And it's very important to consider an early referral to a liver transplant program for the pretext for whether are unifocal or multifocal or unifocal tumors that are centrally located involving the main hilar structures or the main hepatic veins that make resection with negative margins almost impossible. So factors contributing to improved survival is complete resection as soon as possible after induction therapy. Do not delay looking for a transplant. That's why it's so important an early referral and good response to chemotherapy. And then remember that lung metastases are not a contraindication as long as they can be resected. So hepatocellular carcinoma is much rarer, as we have mentioned. So about the 95% of the tumors in the liver in children older than 15 are hepatocellular carcinoma. So there are two broad categories. One is hepatocellular carcinoma in the context of underlying liver disease, and the other is the de novo hepatocellular carcinoma. Among the de novo category, we have about three categories. One is the conventional hepatocellular carcinoma. Another one is what we call the fibrolamellar hepatocellular carcinoma. And then a third is a new category that has some elements of hepatoblastoma and that we call either transitional liver cell tumor or hepatocellular neoplasm, otherwise unspecified. The biology of hepatocellular carcinoma is very similar to adult hepatocellular carcinoma with alteration in genes involving damage and repair, multiple chromosomal imbalances, activation of Wnt pathway and others, increased expression of angiogenesis pathway factors, and for in patients with a fibrolamellar hepatocellular carcinoma, the presence of the specific fusion that defines a disease, DNA JB1 with BRCA. So we talked about the risk factors in hepatoblastoma, now the risk factors in hepatocellular carcinoma, mostly related to congenital errors of metabolism, but then also exposure to viral factors, particularly hepatitis B and hepatitis C. So some general concepts about hepatocellular carcinoma, as we said, is a tumor of the adolescent. The fibrolamellar variant is about 20 to 25% of the cases, and it's characterized by a much more protracted clinical presentation and a lower to normal alpha fetoprotein with a more aggressive behavior with metastatic disease, extrahepatic extension, multifocality, or associated with cirrhosis. And the response to chemotherapy is very poor. So sorafenib is usually added to the standard cisplatin-based regimen. So a complete resection is almost never possible. Less than 30% of the patients can actually have a complete resection. We can use chemoembolization, and then we almost always need to refer these patients to a liver transplant as long as they don't have extrahepatic disease. The outcome is very poor. Less than 30% of the patients survive. So putting it all together, long-term effects of patients with liver tumors, think about chemotherapy, hearing loss, therapy-related AML, cardiotoxicity, renal toxicity. In patients that have a transplant, think about post-transplant immune suppression. And then remember, there is a subgroup of patients with hepatoblastoma on whom there is a family history of familial polyposis syndromes. So remember about the surveillance guidelines with an annual sigmoidoscopy from age 13 to 15 onwards, prophylactic colectomy, usually between 16 and 20 years of age, and then 3-yearly upper GI after 30 years for the risk of small bowel carcinoma. Okay, now we move to the third category, germ cell tumors. So again, rare malignancy, about 3% of all pediatric cancers with a bimodal age distribution, a peak in the first 3 years of life, and another peak in adolescence. The peak in the early life is about extragonadal and testicular tumors. In the adolescence is usually gonadal tumors. So there are two main categories in histology, one seminomatous or germinomatous germ cell tumors that are called seminomas in the testes, these germinomas in the ovary, or germinoma if it's extragonadal. Non-seminomatous or non-germinomatous germ cell tumors are the most common in children. So embryonal carcinoma, yolk sac tumor, the most common, choriocarcinoma, and then teratoma. That can be mature teratoma or immature teratoma if there are any components with neuronal differentiation. And so we classify them in two categories based on age, mostly. Type 1 is germ cell tumors occurring the first 4 years of life, usually teratoma or a yolk sac tumor or a mixture of both. Type 2, usually puberty through through young adults, has a full range of germinomatous and non-germinomatous histologies, and it's often associated with a presumptive precursor lesion that we call germ cell neoplasia in situ. So the biology of germ cell tumors is also very unique. As we know, they arise from primordial cells that are involved in gametogenesis at different stages of development, and some of them undergo this abnormal migration that can lead to the midline extragonadal tumors. The genetics, type 1, the younger patients usually gain or loss of chromosomes and partial loss of genomic imprinting. Older patients are characterized by amplification of chromosome 12, usually through an isochromosome 12p, or amplification of X chromosome, and also with loss of genomic imprinting. So type 1 and type 2 exhibit distinct gene expression profiles, and there are also distinct miRNA landscapes that can be used in the future as tumor markers. There are some unique risk factors, genetic syndromes like Klinefelter's or gonadal dysgenesis like Swyer or Turner syndromes, or anatomic cryptorchidism or genitourinary anomalies, particular hernia or hydrocele. How do pediatric germ cell tumors present? So ovarian germ cell tumors present with abdominal pain, a palpable mass. Think about a sex cord stromal tumor, we'll review that later, if the patient presents with precocious puberty or with amenorrhea and virilization. Testicular tumors usually present with irregular, non-tender masses, and extragonadal tumors, depending on the location, sacrococcygeal, may present with constipation, urinary retention, or even paraparesis, mediastinal tumors with chest pain, respiratory distress. And diagnosis usually with good imaging, CT, MRI of the primary, and metastatic workup with a bone scan and chest CT. So clinical presentation also depends on age and site. So girls usually tend to have ovarian tumors after age 3, boys testicular tumors before 4 or after 13. Then the extragonadal tumors also vary by age. Sacrococcyx before age 4, mediastinum after age 9. And the majority of those patients with extragonadal disease have what we call a stage 3 or 4. And then the site. So the majority of germ cell tumors present with extragonadal sites, 60% versus 40%. In younger prepubertal patients, extragonadal tumors are more common than gonadals. After 15, gonadals are more common than extragonadals. And then the histology is associated with tumor markers, as you know. So yolk sac tumor is associated with high AFP, choriocarcinoma with high beta HCG. Embryonal carcinoma may or may not have low elevations of any of those. And germinomas and teratomas usually are not associated with a tumor marker. So now that we have seen liver tumors and germ cell tumors, let's talk for a second on the tumor marker kinetics. So alpha-fetoprotein, as we know, is very elevated, normal values in newborn greater than 40,000 or 100,000 in preterms, and the adult levels are not reached until after 8 or 9 months of age. The half-life is long, 5 to 7 days, but has wide variability in the first year of life. So that's difficult to interpret response to therapy. So in general, elevation of AFP suggests active disease, but remember that in infants, they may have a slow rebound in AFP after completing therapy. There could be an abrupt increase in AFP during early therapy, like a tumor lysis syndrome. Then there could be a spurious persistence of AFP elevation when there is liver function alteration, like in viral hepatitis or cholestasis secondary to anesthesia or some exposure to some drugs. And then there are other malignancies that may cause AFP elevation, like hepatoblastoma and pancreatoblastoma. And then beta HCG The normal values always at any age should be below 5, and so that the half-life it's much shorter, so it's much easier to follow. In general, any elevation of beta hcc suggests active disease, but remember that there are a few other examples like iatrogenic hypogonadism or other malignancies in adults that might be associated with beta hcg. So the staging of germ cell tumors follows the typical staging system: 1, 2, 3, 4, based on surgery, complete resection and normalization of tumor markers, microscopic disease, but or persistent marker elevation, or enlargement of lymph nodes. Stage 3 is gross residual disease, larger lymph nodes. Stage 4 is the presence of distant metastases. So how do we stage testicular versus ovarian tumors? That's important from a surgical point of view. So for testicular tumors, an inguinal incision and radical orchiectomy with high ligation of the cord structures. Then we assess the retroperitoneal lymph nodes by CT. If the lymph nodes are less than 1 centimeter, we consider them negative. They are greater than 2 centimeters, we consider them metastatic. Something in between needs close follow-up because they could be reactive. In case of a scrotal orchiectomy, that may remain on stage 1 if the margins are negative, an appropriate decline in the tumor markers has been documented, but still needs to complete the surgery with proximal cord structure resection. If the patient had a scrotal biopsy, not a resection, then the scrotum is contaminated and by definition is a stage 2, but hemiescrotectomy is not required. You still always need to complete orchiectomy. For ovarian tumors, ovarian germ cell tumors are usually very large and very friable, so there is always a risk of intraoperative spill. So there are different components that need to be considered by the surgeon: good cytological assessment of the peritoneal fluid, inspection and biopsy of any abnormal appearing peritoneal surfaces, and then removal of the primary tumor without violation of the tumor capsule. And then failure to document inspection and confirmation of normal appearance of these other structures uh, precludes eligibility for the surgery-only approach because a proper staging has not been completed. So how do we manage these patients? For stage 1 germ cell tumors, if they are gonadal tumors right now, the recommended treatment is surgery and observation as long as the tumor markers have normalized. So if the tumor markers then can be followed on a monthly basis, that would be the most recommended treatment. If the markers fail to normalize, then the patient is automatically upstaged to stage 2 and treated appropriately. About 30 to 50% of patients with a stage 1 gonadal tumor may recur after surgery, but salvage rates are very high and survival is still 95%. So the standard of care right now is surgery only for the stage 1 gonadal tumors with a very close follow-up. All other patients require surgery and chemotherapy. Then we use some risk adaptation and intensification, but the standard of care is basically what I will show you in the next few slides. And again, radiation therapy is not indicated in upfront management of malignant germ cell tumors. So how do we assign this risk? Stage 1, as we said, represent a low risk group, particularly gonadal germ cell tumors. Stage 2 through 4 gonadal germ cell tumors appear to be an intermediate risk group, except maybe for older patients with gonadal tumors that seem to have a higher risk of failure. Then patients with advanced extragonadal tumors represent the highest risk. Older patients tend to do much worse than younger patients, and there is an interaction between that age and the primary site. Young patients tend to have sacrococcygeal tumors that do very well. Older patients tend to have mediastinal tumors that don't do as well. And so if you put it all together, these would be the 3 categories that you would consider. Low risk, patients with stage 1 gonadal or stage 1 immature teratoma, surgery only leads to greater than 95% cure. About 30 to 50% of the patients, as we said, may recur, but you may still be able to salvage them. Intermediate risk category, stage 2 through 4 gonadals, stage 1 and 2 extragonadals, surgery and chemotherapy, greater than 90% survival. High-risk patients are usually considered to be the stage 3 and 4 extragonadals. The treatment is basically the same, surgery and chemotherapy, just that the outcome is a little bit worse. And studies are undergoing to evaluate the value of intensifying therapy in those patients. So what kind of chemotherapy we use is platinum-based regimens that we call PEB, cisplatin, etoposide, and bleomycin. In adolescents, we use the adult regimen, which is with a capital B, and is weekly bleomycin. In Europe, particularly in the UK, a treatment that is very popular and almost equally effective is carboplatin instead of cisplatin, and we use the same, CEB. The current trial that many of you have in your centers randomizes cisplatin versus carboplatin, so it's a direct comparison of PEB versus CEB. In Europe, they use VIP, in Germany particularly, using etoposide instead of bleomycin. Ifosfamide instead of bleomycin. And we consider this regimen a good regimen for patients with mediastinal primaries because it's associated with lower postoperative complication rates as you could imagine, because you don't use bleomycin. So the standard approach is stage 1 gonadal observation, stage 1 extragonadal, and all stage 2, 4 cycles of postoperative chemotherapy, stage 3, 4 cycles followed by surgery. In the past, we used to do 2 additional cycles after surgery, but the role of postoperative chemotherapy for residual disease is unclear. So bottom line, cisplatin-based therapy or carboplatin-based therapy and surgery. And finally, a couple of words on sacrococcygeal germ cell tumors, very rare, 1 in 35,000 live births. There are 2 distinct clinical patterns. You see how, in the figure on your right, the 4 types based on the component outside and inside of the pelvis: type 1, type 2, type 3, type 4. The most common is type 1, with the majority, most of the tumor outside of the pelvis. But then there are 2 patterns, as we said. One is this, a newborn that presents with a large, predominantly external tumor that is usually detected prenatally or at delivery, rarely malignant, less than 10% have a malignant component. This is stage 1, resected up front. Older infants and young children usually are type 3 and type 4s. The tumor is less apparent, and this tumor may transform, and 60 to 90% of these patients then present with malignant disease, stage 3 and stage 4, with abdominal pain, constipation, bladder dysfunction, neuropathy, and metastatic disease. So the pathology, teratoma or immature teratoma, and most of those that have a malignant component is a yolk sac tumor. Treatment: stage 1, surgery alone, remember, coccyrectomy always. Then stage 2 through 4, surgery plus chemotherapy. But even for a stage 4, the outcome is excellent, with a survival of greater than 90%. Long-term effects of therapy for patients with germ cell tumors are those related to chemotherapy, as you can imagine: hearing loss, neuropathy, therapy-related AML, cardiotoxicity, renal toxicity, and pulmonary toxicity. But then in those patients with more advanced sacrococcygeal teratoma, bladder and bowel dysfunction, either because of the tumor itself or because of the surgery, are not uncommon. And then finally, in the last 10 minutes, we will review the other rare tumors. And so the other rare tumors are a large category that I have tried to summarize in 5 categories that I thought would be important, at least for your practice. Starting with the ovarian sex core tumors. These are tumors that typically present in the first 2 to 3 decades of life, account for approximately 5% of ovarian malignancies in the second decade of life. Clinical presentation, like symptoms of an adnexal mass with abdominal pain, distension, or acute pain due to torsion. Signs of hormonal production are very common. So think about hirsutism and virilization, menstrual changes or precocious puberty. Then think about family history, because often are associated with tumor predisposition syndromes. Think about a good physical exam that can give you a clue about this diagnosis: precocious puberty, delayed menarche, secondary amenorrhea or virilization. And then patients may have hyperpigmented macules that's associated with a Peutz-Jeghers syndrome, or thyroid nodules with a Dicer-1 syndrome that we'll review in the next slide. So there are different histologies: adult granulosa cell tumor, juvenile granulosa cell tumor, Sertoli Leydig cell tumor, sex core tumor with annular tubules, and gynandroblastomas and other mixed forms. The most common in children are juvenile granulosa cell tumor and Sertoli Leydig cell tumor. And approximately half of the patients with the Sertoli Leydig cell tumor and Hepatoblastoma have a germline mutation of DICER1. This is something that you all need to remember. And this is a table that can give you an idea of what to think for and what syndrome to consider. We have just talked about DICER1 germline mutations associated with Sertoli Leydig cell tumors and gynandroblastomas, and the DICER1 syndrome here to remember pleuropulmonary blastoma, embryonal rhabdomyosarcoma of the uterine cervix, renal tumor, thyroid nodules and carcinoma, and others. Sex cord tumor with annular tubules is what you would expect in a patient with a Peutz-Jeghers syndrome, and that's associated with the germline mutation of STK11. Then juvenile granulosa cell tumor um, may be associated with Olier's disease and Maffucci syndrome with IGH1 and IGH2 mutations. And adult granulosa cell tumor is not associated with a germline mutation, but a somatic mutation in FOXL2. How to evaluate these patients? Inhibin in the laboratory evaluation, inhibin B is more predictive than inhibin A. We also look for estradiol and testosterone, or even alpha-fetoprotein that is elevated in Sertoli Leydig cell tumor. Imaging with a standard abdominal imaging, family history and genetics testing and counseling are recommended. Treatment is surgery with fertility sparing surgery whenever possible. Then the adjuvant treatment is stage dependent, and for that we use the ovarian staging system that we call FIGO, that probably you don't need to remember, but for early stage, completely resected surgery can be curative. Then for other patients, stage 1C and above, we recommend standard BEP or germ cell tumor chemotherapy. Second disease is melanoma. That's actually a very rare cancer, but not so uncommon after adolescence. So the risk factors are giant congenital melanocytic nevi and xeroderma pigmentosum and others. And there are about 3 types of pediatric melanoma biologically. One is conventional melanoma, usually with mutations in BRAF, V600E, TRET, and PTEN. Spitzoid melanoma that usually has kinase gene fusions, not so many mutations, and melanoma arising in a giant congenital melanocytic nevi that is characterized by NRAS mutations. So the clinical presentation of melanoma is very well known to you. Think about the ABCDE, asymmetry, border, color change, diameter, and evolution over time. But remember that only about 50% of children present with a conventional ABCDE criteria. Other signs of melanoma in a hyperpigmented lesion, bleeding, itching, or even a pyogenic granuloma-like. The diagnostic evaluation is with a biopsy or excision. Sentinel lymph node biopsy is done for lesions that are greater than 1 millimeter or lesions that are less than 1 millimeter but have high mitotic rate or present with ulceration. Then imaging is local regional imaging, chest imaging, and for patients with more advanced disease, PET is recommended. Staging is a standard AJCC with the TNM staging, and tumor genomics, as we have discussed in the prior slides, are important to identify targetable alterations. So how do we manage melanoma? So first, surgery is the treatment of choice, and the wide excision is critical. So the margins are in direct correlation of the size of the tumor, 0.5, 1, and 2, based on the thickness of the tumor. For patients that have a positive sentinel node, the recommendations are either ultrasound observation of the nodal basin versus considering lymph node dissection, and then also consideration for adjuvant therapy, either checkpoint inhibitors or BRAF or MEK inhibitors. For patients that have clinical nodal involvement, palpable nodal involvement, these patients require wide excision, no dissection, and oftentimes local regional radiation therapy, and again, considered adjuvant therapy, checkpoint inhibitors, or BRAF MEK inhibitors. And for patients with metastatic disease, surgery whenever possible, and then again, checkpoint inhibitors or BRAF or MEK inhibitors. Then thyroid carcinoma, that's also a very rare cancer, but not uncommon in adolescents, as we said, for melanoma. It's also higher in whites than in blacks. There are some risk factors, particularly ionizing radiation exposure and some familial cancer syndromes, medullary thyroid carcinoma associated with the MEN syndromes. Differentiated thyroid carcinoma is associated also with APC polyposis, PTEN, hamartoma syndrome, even Dicer-1 syndrome, as we discussed. There are three types of thyroid carcinoma that you can review in more detail: differentiated thyroid carcinoma, medullary thyroid carcinoma, and anaplastic carcinoma. So how does thyroid carcinoma present? Usually with a thyroid mass, some stigmata of cancer predisposition syndrome. Younger patients tend to have more aggressive presentation. Usually the differentiated thyroid carcinoma presents in adolescents, medullary thyroid carcinoma in younger patients. Diagnostic evaluation with good imaging of the neck. Usually, we do not require iodine scan at baseline in all cases. You will see the next slide, as it can be risk adapted. Then there are some labs that you need to remember: thyroglobulin in differentiated thyroid carcinoma, calcitonin in medullary thyroid carcinoma. And staging is based on AGCC and tumor and germline genomics, as we described. So the treatment follows the ATA, the American Thyroid Association guidelines. I will not describe them here in detail. You can take your time to review them, but remember that this is risk adapted based on the ATI risk criteria, and that will define the type of surgery and the need of iodine radioablation. Medullary thyroid carcinoma is very unique. It's very rare. We also need to have a very aggressive surgical approach. What is unique about this is that the majority of cases are associated with an MEN2 syndrome. And so early genetic testing and counseling is required. Prophylactic thyroidectomy is recommended for children with a germline RET mutation. There are different types of mutations that have a higher or lower risk. And based on the type of mutation, the total thyroidectomy is done early in life or later in life. That's all you need to remember. And then for patients with metastatic or unresectable disease, there are now RET inhibitors that have been shown to be very effective. So finally, nasopharyngeal carcinoma, very rare as well, has an endemic form in in Southeast Asia, North Africa, and the Mediterranean basin. The majority of patients have evidence of past EBV infection. There are some environmental factors in the endemic forms related to volatile carcinogenic nitrosamines and some genetic predisposition. There are three types of nasopharyngeal carcinoma histologically: type 1, 2, and 3. The most common is type 3, which is undifferentiated carcinoma or lymphoepithelioma, is the most common in children, also the most common in the endemic forms. Usually patients present in the second decade of life. It's male preponderance with nasal congestion, bulky cervical lymphadenopathies. Diagnostic evaluation: good nasopharyngeal scope, good imaging of the head and neck, EBV serology and EBV DNA levels, and a biopsy of either the primary tumor or a lymph node. Staging is based on AGCC. Differential diagnosis is with sarcomas and esthesioneuroblastoma. Treatment is combined chemotherapy and radiation therapy. It's usually 3 cycles of cisplatin and 5-FU, followed by chemoradiotherapy, that is radiation therapy with cisplatin. Long-term effects are those related to the treatment itself: hearing loss, dry mouth and dental problems, trismus, and hypothyroidism or panhypopituitarism. The last 2 slides. So pleuropulmonary blastoma, we have already mentioned that when we talked about Dicer-1 malignancies, presents in 4 main forms, which are associated with prognosis. Type 1, which is cystic, that's early in life, treated with surgery only, excellent outcome. Type 1R is a regressed type 1 form with an excellent prognosis. Type 2 is a mixed cystic and solid, presents a little bit older, about 35 months, and a 5-year overall survival of about 70%. And type 3 is fully solid, older patients, worse prognosis. So they present in a continuum of presentations. So clinical presentation is non-specific, usually respiratory distress, pneumothorax or chest pain. About 30 to 50% of the cases present with multifocal or bilateral disease. And types 2 or 3, those with a solid component, have a higher risk of brain metastasis. The pathology of type 1, usually multilocular cysts with some primitive mesenchymal cells. Types 2 and 3 have this mixed blastomatous and sarcomatous, looking like a rhabdomyosarcoma, oftentimes with anaplasia. The treatment is surgery for type 1 and surgery and chemotherapy, usually sarcoma therapy for types 2 and 3. The last slide, adrenocortical carcinoma, very rare. Remember, though, that it's almost always associated with a cancer predisposition syndrome. 50% of the cases have a p53 mutation. So these are Li-Fraumeni syndrome. Other syndromes associated with adrenocortical carcinoma include Beckwith-Wiedemann syndrome and hemihypertrophy, as we mentioned, NF1 and MEN type 1. Typically presents in the first 2-3 years of life, median about 38 months, female predominance, and almost 90% of the cases with virilization. Cushing and mixed syndromes are less common. Treatment is surgery, surgery, surgery. There is a risk of tumor spillage, so you need to be very careful. Surgery alone can be curative for the small, completely resected tumors. For others, we recommend surgery and chemotherapy includes mitotain and cisplatin-based regimens. And with this, we will conclude. Sorry that it's a little bit long, it's very dense, but hopefully you have the material to spend time going over the different categories of different diseases. I will be happy to take any questions. Thank you, and good luck with your exams.
Hi, thank you, Dr. Rodriguez Galindo. We now open up the Q&A portion of the event. We had 26 questions that have been answered, and so wanted to give Dr. Rodriguez Galindo the chance to kind of highlight ones he felt were the most important.
Yeah, thank you. I think the questions were very helpful, so hopefully everyone had also a chance to go over the questions, because there were a few points that actually were very relevant and that maybe in the slides were not clear. A lot of questions are very unique scenarios that are highly unlikely to be part of the board question. So I know that it's a very dense topic with so many diseases in just 1 hour. We had to record it twice actually because it was too long the first time. But I'm happy to communicate by email if anyone has questions. One of the common questions about the screening of children with bilateral retinoblastoma or children born to families with bilateral retinoblastoma. And so screening is a key issue with retinoblastoma. Any child born to anyone with retinoblastoma history should be screened with dilated eye exam. And usually you do it under anesthesia at birth because babies do not cooperate that well. But then if the genetic testing is negative, then you can ease up that, obviously. And so for any patient that has a germline mutation, then you need to screen that patient every 4 weeks, if that baby every 4 weeks, because the penetrance is very high. So for sure, in the first few weeks of life, that kid will develop retinoblastoma. So a negative exam under anesthesia at 4 weeks of age doesn't tell you much. So because most likely that kid at week 6 or at week 8 will start developing tumor. So you need to be very vigilant. That I think that might be a board exam question: screening, dilated eye exam, and do genetic testing and genetic counseling. So there is a question here about the pineal cysts. Yeah, that's a very good question. And so pineal cyst is not a retinoblastoma-related disease. Normal populations, that is normal kids, if we screen normal kids, you will find pineal cysts. So what do we see in bilateral retinoblastoma children is that the pineal gland is slightly larger than a non-bilateral retinoblastoma child. And so we have measured that, and the pineal gland may just get up to 1.5, even 2 millimeters. And so that is a little bit bigger than what you would expect. And so what usually happens is that then, this pineal gland reaches a maximum and then starts shrinking or just normalizing, and some of these patients develop a pineal cyst. We don't have population-based studies to really screen. In our experience, we have seen cysts in somewhere between 20 and 30% of patients with bilateral retinoblastoma. So in any child with bilateral retinoblastoma that has a slightly enlarged pineal gland, you don't need to call it trilateral right away. So you need to be careful, you need to monitor that, just repeat another MRI, see what happens with that pineal gland. And then if it continues to grow, then yes, then you confirm that this is a tumor, right? But oftentimes the pineal glands are a little bit larger. The moment they develop a cyst, then it's no longer a trilateral retinoblastoma because a pineal cyst is a normal entity. Okay, so hopefully that helps. There is a question about ocular melanoma. Yes, ocular melanoma is a completely separate entity also biologically. So we did not cover that just because it's so extremely rare in children. So we did not talk about ocular melanoma, but it's a different entity that I think in my career I have seen it only once, and I have seen probably 500 or more children with retinoblastoma. So it's very rare. You will not, probably will not encounter that in your practice.
To go over some of the questions that have already been answered, just to have them on the audio recording. What is the difference between exam under anesthesia and dilated eye exam?
Yeah, that's a good question. So, all children with retinoblastoma or that are being screened for retinoblastoma need to be examined with dilated eye exam. That's obvious. The question, though, is that babies do not cooperate, as you can imagine. And so it's very difficult for an ophthalmologist to do a very good exam looking at 360-degree evaluation of the retina, anterior and posterior retina, because you need to move the eye. And so that is why we do exams under anesthesia. So the kid needs to be put under anesthesia so the ophthalmologist can do a good exam. That's the only difference. Once the child is 4 or 5 and can collaborate, yes, look up, look down, and the ophthalmologist can see it. Now, that's for screening. For treatment, I think all children need to be put under anesthesia because the eye needs to be still. You need to do laser. The laser needs to focus very well. So then anesthesia is required. So hopefully that clarifies these two scenarios. Treatment of metastatic disease in patients with HRRB, which I assume means high-risk retinoblastoma, right? So let's start with that. So two concepts. One is high-risk retinoblastoma, probably with high-risk pathology. So about 20 to 25% of children with unilateral enucleated retinoblastoma have high-risk pathology. So a very small number of a small proportion of those might have metastatic disease. But let's assume that the majority of kids with high-risk pathology, that it's massive choroidal involvement, maybe, post-laminar optic nerve involvement, have high-risk pathology. That's how we call it. So these patients are treated with systemic chemotherapy. None of them most likely will have metastatic disease. Now, then you have the patients with metastatic retinoblastoma. These are usually kids that come with extraorbital disease or kids that you have enucleated before and then recur with metastatic retinoblastoma. And so any patient with metastatic retinoblastoma requires very intensive treatment, whether it comes up front or comes after relapse or after enucleation. And so the treatment for those children, which I believe is the question, is high-dose chemotherapy, cisplatin-based therapy, and high-dose chemotherapy with autologous stem cell rescue. So that's one of the very few, similar to neuroblastoma, solid malignancies in which autologous transplant is recommended. So there is a COG trial that will be published soon that shows survival rates at 2 or 3 years above 80% for those patients. Without transplant, it's very difficult to cure them. I hope that clarifies that, but happy to communicate by email if this was not the point of the question. Okay. So do all patients with hepatoblastoma need a screening for APC mutations and Gardner? different groups do different practices. In many cases, I almost always recommend it. So whenever a kid comes with hepatoblastoma, I think that one of the first things that need to be screened is for any APC mutation. Some groups do germline mutation studies for all children with hepatoblastoma. Others just follow family history, and then based on that, they do a risk assignment. But I think that it's something you need to think about. You need to screen for that, and then in some cases you need to um, to offer genetic testing.
This is all the time that we have. Thank you for attending this session. The chat and Q&A have now ended. The recording of this session will be available on the page later today. Also, please watch for further details regarding the virtual office hours in late February and March for an additional opportunity to ask questions and to interact with the speaker. Finally, don't forget to visit the Launch Network chat button in the top right corner and set up your chat profile to connect with peers throughout the course and during breaks. The next session, Immunology and Immunodeficiency, will begin at 12:30 Central Time. Please exit this room and join that session's room at the appropriate time. Enjoy the rest of your course. Thank you again.
Thank you. Good luck.